So this is a 40-year-old patient who had a dysplasia, and as you can see, he had a previous osteotomy there for which a plate was removed about 10 years back. Then he sustained a fracture of the upper fourth of femur, which was plated, and this is the situation that the patient presented to us for a total hip. Now his hip is painful. Peter, his spine, you take my word, is normal.
Okay.
You would ask for that. So his spine is normal. We are discussing the hip, and this is the anatomy. So basically, we have to discuss the implant choices in this case. You want me to move
definitely.
on?
I think it's good that we can talk about this here. I guess first of all, any issues with the panel? Any ruling out infection or other concerns? You know, before we think about
No, CRPs are normal. The plate has been there for a lot of time, now almost 8-9 years.
Sure. Thorsten, any thoughts? I mean, do you rule out everyone for infection if you see prior hardware? What's your workup?
Yeah, okay. You can rule out, we have to rule out always the infection. You have to control the CRP. And if everything is normal,
Everything
the
is
wound
normal,
looks
yeah.
normal, then it's okay.
Okay.
The hip looks quiescent clinically. I mean, clinical judgment is also important. So clinically, it's fine, and CRPs are normal.
Okay, great. So I think, well, for the panel, is this going to be a procedure that's going to be staged or simultaneous? Does anyone think that this should be done by, taking out the plate, taking cultures, and then coming back, or is this something you're all going to manage in a single stage? Any comments? Just going down, maybe down the panel, single stage, or for all of it, for everyone. Would anybody want to stage this, and why?
I'm a bit concerned about the periosteal reaction, all these things which is there. So I would prefer to do it two stages, take out the implants and then do. And since there is no medullary cavity, so this is one of the indications what we are discussing in the last session, that about doing resurfacing. This is one of the indications of doing resurfacing or a short stem kind of thing, because the medullary canal is.
I don't think, Dr. Mohanty, this is a great case for resurfacing.
Because head neck offset, if you see here, and I think I would agree with Dr. Jarani that it is, I believe it's not infected, so I would do it in one stage.
Okay.
We have to keep one thing simple. Acetabulum is quite simple. As far as femur is concerned, we need to get the proper reaming so that we're using like a nailing reamers. So get hold of the canal. Don't remove the entire screws in the distal part of the plate till you've got your stem to the right area. Once you're happy with it, it's possible that I may not remove the lower part of the screws, leave the top part, and put the stem inside and prevent the periprosthetic also.
Okay.
So this fracture is 12 centimeters from the greater trochanter, and most stems are 135.
Okay.
So, can you see the case there, Peter? All right. So, so any standard stem would hit the fracture. So that's a typical double-tapered, proximally coated smallest stem. And if you choose a cemented stem, then that would compromise the fixation because it's only 40-year-old and the screw holes would jeopardize the cementing. And if you do an osteotomy and choose a long stem, that would also not fit because the femur is bowed. As you can see, the femur has got a S-shaped bow there. So a standard stem, a cemented stem, or a long stem.
Yeah. Thorsten,
Yes,
yeah.
Thorsten.
So during the previous discussion, I mentioned that I never do a resurfacing, but here I would consider a resurfacing because then you are out of all these problems. I would send them to this patient to VGI for a resurfacing, to be honest.
Is this? The
So-
acetabular side
This-
looks
this
complicated.
socket-
The femoral head looks. Yeah, the sizing looks difficult for this.
Yeah, so resurfacing is not available in less than 50 socket. It's been withdrawn, BHR. So this is a 50 socket.
Many times in sickle cell also, we don't find the canal. We ream it and make the canal. You can use the small stem or standard stem after reaming it.
And what kind of reamers do you use? Do you use reamers? Some of you use them from the elbow, really small humeral nail reamers.
Small humerus.
And you can they're cannulated. Some of you actually do cannulated reaming over a wire from an elbow or the humeral head system. How about a Wagner cone? I'm just kind of thinking, Thorsten, do you have any experience? I mean, you showed the SL, but what about a shorter cone type?
Yeah,
Wagner?
yeah, okay. Wagner cone could be a good idea. It's shorter, and it gives you a very well fit. It is an option. I would ream it.
But if you look at the
manipulated.
lateral view carefully, there is a procurvatum deformity there. So I don't think you can negotiate.
That's what I'm worrying about, because there is a deformity, and I'm not sure. The Wagner stem is quite short, the cone, but I'm not sure if it passes the.
Just one thing, because it comes in very small size. In sickle cell patients, the Wagner cone works quite well in that kind of sclerotic canal.
So then we looked at the smaller uncemented stems. Okay, Metha is one of them, which is by the Asclepius, but the anatomy for Metha has to be perfect. I mean, the preparation is such that the calcar has to be good. So then we thought of the SMF stem, which is a small uncemented stem. It's 100 millimeters, and that's what we used as the dysplastic socket. We removed the proximal screws, and we used a short stem, the SMF stem, and we were very meticulous with the preparation, because preparation is critical. You just have that proximal 3-4 centimeters of fixation.
Yeah.
And that's the follow-up. There is no subsidence.
How long is the follow-up?
2.5 years.
2.5 years.
Looks great.
And,
Any thoughts on
you
weight bearing from with anyone in the panel? Full weight bearing, toe touch, partial, and for how long? I mean, let's ask the panelists. Full weight bearing? If the fixation is.
Dr.
good
Loop,
trouble?
just one concern. How about the offset? Don't you think the offset is quite less, horizontal offset, compared to the normal side?
Yeah, but it was a dysplastic case. So when I chose the higher offset, I was not able to reduce it. So it was that tight. Because as you can see, we brought the hip down. It was way up, and we brought the center of rotation to its normal position. So it was difficult to reduce it with a higher offset.
Tell her about the socket side. I mean, you went with the larger cup. Did you template trying to go smaller, medializing, and then maybe even using bone graft superiorly? Or the thought to ream out to the rim on this?
We just
socket?
brought it down to the teardrop and chose the right size. I think it was a 50 cup.
Cup, okay. As ischial spine sign on the left side there, so risk for acetabular retroversion when you have that spine sign in the pelvis.
Would
No,
anyone
that was a malunited fracture. That was a malunited fracture and the malunited osteotomy. So he had two proximal femoral procedures. One was a proximal femoral valgus osteotomy long time back, and the second was the fracture. So I think that's because of that.
Definitely. Okay, comment?
can we consider using the short cemented DDH stem in this?
You can, but with a 40-year-old Ninal, it would compromise the fixation with the screw holes. You can use a 33 exeter, but that would be a wide canal and a thin stem that would, in a 40-year-old patient, I would be hesitant to do that.
I think the take-home point in this case is you tried so many different stem designs, and you found one that fit perfectly. So
right.
you can't just have one stem or two stems.
That's right.
You tried 5 or 6, and then you found the right one. So
Yes, that's right.
power of versatility,
Yeah, and that's, you can see some signs of early bonding there at 2.5 years follow-up.
Yeah. Wonderful case. Yeah, any other final comments? I think it was great.
No.
Perfect. Okay, excellent.